Thank you, John. Greetings from across the pond. I'm in the United Kingdom here.
Right.
I've got a background, 25 years as a practitioner, 10 years as a master prac. I've got a background in the National Health Service over here and the military, Royal Marines. Attempting to get NLP welcomed and undertaken with the National Health Service here, it's just an uphill battle. They'll prescribe cognitive behavioral therapy and they'll say, yes, that's evidence-based. The only research I've got, and this is 10 years ago, was NLP and post-traumatic stress disorder, the visual kinesthetic dissociation protocol. And it references your work, Whispering in the Wind, Robert Dilts, some of Richard Bandler, and some of Steve Andreas's work. I'm just, curious if somebody's got a better strategy to get this in the National Health Service over there, because it's crippled. It really is. There's not enough people doing talking therapies. There's not enough people who can deliver, interventions. And the amount of chronic anxiety and stress and, depression since lockdown, it's gone up about 75, 85%.
Okay, so you're looking for, if possible, some way to correct the disdain which National Health seems to have for the patterning that you've used for the last 25 years, I presume.
Correct. That's been very polite, using the word disdain.
Yeah. This is an ongoing problem that I've had since Bandler and I, many decades ago, began this project. There are obvious obstacles to a incorporation of the patterning. By the way, let me also ask you, Leslie, have you had training in new code?
No, never.
Okay.
I read about it about 2003. But,
yeah. If you have the opportunity, I urge you to bring yourself up to a present state patterning competency, because the new code is quite distinct from the classic code that you were originally trained in. We both know the classic code does work. You have many examples of it in your own experience. However, that's independent of the question how you get it into the National Health Service in the United Kingdom, or any place in the world, as a matter of fact. Let's be quite frank. There is a downside for someone who's trained as a medical professional when it is demonstrated by example that there is a set of patterns, whether it's the classic code or the new code, which I would urge you to get, that is more effective over a wider range of cases, much faster, and does not involve the imposition of content. This is, of course, the first and single most relevant difference, I think, between standard medical practice and so-called evidence-based medicine and evidence-based services, and what we are actually doing. Evidence-based sounds really comforting to me. It's a really nice title. However, if you look at what's actually going on, it should be called statistically evidence-based medicine, statistically evidence-based psychotherapy, coaching, etc. Because, as you know, there are no diagnostic categories in NLP. How is it possible to do the kind of remarkable work that's been demonstrated effectively for decades, in your case, without having a diagnostic category? And the answer is, that's exactly the difference between process and content. What is evidence-based medicine actually? It's the sorting of patients into categories by their symptomology, their response to the various standard treatments in medicine. That is to say, is statistically based. So if you want to operate as a physician, at least in the United States, and I suspect this is true, the National Health Service in the UK, you're going to have to pay attention to what is approved statistically based treatment programs. Because especially in the United States, I think less so in the UK. If you stray outside of those lines, you're opening yourself up for a possible legal action if, in fact, the patient is not happy with the results. So that's an important thing to recognize, that I do not see any antagonism between the training that a good medical professional or a good content-based coach or psychotherapist has, except the problem about imposing content. If it's a statistically based treatment program, then it's going to work for some percentage, differing therapeutic content by therapeutic content, and it's going to equally not work for some percentage of the people sorted into that particular. So the evidence that's involved is a amalgamation of symptomology and results from treatment programs. And this is the standard Western medical model. So let's go back to my question. How could we do the work that we do without a diagnostic guide? And the answer is calibration, the mother of all skill sets in NLP. If you use a statistically based model, then you know that it's going to work for some percentage, varying by the effectiveness of the person applying it. And it equally will not work for some percentage of the category of patients that have been sorted into that diagnostic category. So the answer to your question is, I suspect that there will be people like yourself who use their own direct calibration, their own ability to see the differences that they're creating by the application effectively and congruently of the patterns which you're familiar with from classic NLP. And I hope you enjoy the new code patterning, because it's actually quite a bit faster, and it places more emphasis, as I'm sure Mike has emphasized in his presentation earlier today, more emphasis on unconscious participation as opposed to left brain conscious participation, something, for example, that Robert Dilts is very well known for, and I have critiqued multiple times. So I suspect until the reward systems, that is, what the professional associations are willing to recognize. Now, this presents a problem. If you're going to do statistical based, then you're signing up to be successful with a percentage and unsuccessful with a percentage simultaneously. This seems to be a disservice to anybody who is in the position of patient or client. To know that you're applying a pattern which is going to fail for a certain percentage seems to me to be antithetical to what our job is. I mean, if I had to say in a quick way, and I'm curious about your response to this, Leslie, the idea that you would sign up for something that you know will fail for some percentage is to give up your responsibility. For me, an agent of change, somebody well-trained in the application of NLP patterning, is what I call an agent of change. An agent of change has a single repetitive responsibility, and that is to create a context in which their patients or clients are able to develop effective new patterning, which is designed for them specifically. This is personalized medicine. This is personalized psychotherapy and coaching. And that seems to me to be, and until that responsibility is accepted by the professionals and the professional associations, I don't think you're going to find it being endorsed by exactly the people that you're interested in having endorsed. That's maybe a little shaky for people who are listening for the first time, but you yourself have demonstrated for decades now that you are able to create these differences which are personalized to the clients that you work with, which give them the choices which they lack when they first enter into a relationship with you as their coach or their psychotherapist, whichever title you decide to use. So I've given a very general answer. I don't think it's particularly encouraging because you're going up against a money system, a system of professionals who are defending their turf. And until those things are dealt with effectively, I doubt that there's going to be anything effective about getting it endorsed as an equal part of the healthcare system anywhere in the United States.